Hey, everybody, welcome back to the Rebel Health Hormone Optimization Masterclass. I'm Michael. I'm going to be your host for all of these presentations. Today, in this presentation, I am joined by Dr. Liz Bartman. Dr. Liz, thank you for being here.
Thank you so much for hosting me. I'm excited.
Yeah, it's going to be a good one. For anyone who wants to nerd out on hormone testing, this is the spot. And, there's a lot of components in this masterclass. We're looking, some presentations are looking at factors that influence hormones. Some are looking more at the hormones themselves and what hormones do what. And this presentation is going to be all about testing hormones, which comes up in a lot of other presentations, that testing is important. You need to know what you're working with. You need to know baselines. You need to follow the biochemistry to see how your body is responding to the things that you're implementing, whether it's dietary changes, lifestyle, supplementation, like hormone therapy, those kind of things. Because without knowing what's going on, you're just kind of guessing and shooting darts in the dark, right?
Absolutely. Yep. It's so true.
Okay. So before we get started, I'm going to introduce Dr. Liz a little bit. She's been on our platform before, so you guys probably have seen her. But if you're new to the Rebel Health Tribe, Rebel Health community, we're going to just give a little introduction, so then we'll get started. Dr. Liz Bartman is a naturopathic doctor with over a decade's worth of experience in functional medicine. She currently serves as a director of clinical sciences at EndoAxis, and Dr. Liz is well-versed in conventional standards of care and enjoys bridging the gaps of treatment and research in both the conventional and functional fields to provide tailored, evidence-based therapies to her patients. Having previously worked as an educational consultant at Precision Analytical, the ones who make the Dutch hormone test, she has educated and consulted with physicians from around the world on complex hormone cases and has spoken professionally about hormone health, environmental toxin impact on health, and nutrigenomic medicine. There are actually presentations on endocrine disrupting chemicals in this masterclass with Laura Adler, and nutrigenomics related to hormones with Jacqueline Downs, who works with Dr. Bob Miller. So both of those topics are covered also. And here we're going to be talking about hormone testing. So if there's anything you'd like to say before we get started, the floor is yours, or you can jump to the screen share and we can get started with the presentation.
So before we jump in, I do want to give a little introduction. So we're going to be talking about the lab testing options for hormones. As Michael already introduced, I am the Director of Clinical Sciences at EndoAxis. Kind of an overview of what we'll be talking about today. To understand lab testing, you kind of have to understand the hormones, which you're getting a lot of information throughout this summit. So I fully trust, I'm not going to go into great detail on the hormones themselves, but I do want to talk about where are these hormones made? Why does it matter? And how does the testing kind of zoom in on what we're seeing, and why would you choose one test over another? So first, let's define a steroid hormone. So when we talk about hormones, we want to define what a steroid hormone is. And a steroid hormone is a cholesterol-based hormone, which means it's fat. And this is important because as a fat-based hormone, it can passively diffuse into our cells because our cells are also fat. So it just passes right in. And that's important to think about. The free fraction will pass right into our tissues. Now, we do have a lot of transport of our hormones, and those are coming through a protein bound. They have to be bound to something to pass in our blood, right? And so that's going to be really the greater fraction of a hormone once it's made from our endocrine tissues, from our ovaries, from our testicles, from our adrenal glands, from adipose even. We need to circulate it in a very water-dominant medium, and that's blood. And so to do that, fat and water don't collide well, right? If you pour olive oil onto a glass of water, it's going to bubble onto the top. That's in free form what you would kind of expect with a steroid hormone in blood. So it has to be added to a protein that can carry it around our body, right? And pump and circulate through to what I call the neighborhoods, or tissues around the body that need those hormones. So steroid hormones, we're talking testosterone, estrogen, and progesterone as our primary sex hormones, as well as cortisol. So these are our cholesterol-based hormones. They're basically signals, right? They act to alter cell behavior, and they do so within the tissue, which is really a potent, strong response. I am going to use the term gonads interchangeably in this talk. And so I do want to define that. Remember, a gonad is a gamete producing tissue. I think colloquially, it often gets referred to as the testicles, but they're not. It's ovaries and testicles, right? Because a gamete is an egg. The ovary makes the eggs, and a gamete is sperm, and the testicles make sperm. So when we talk gonads, they're gamete tissues. So ovaries and testicles. And then when we're talking about the adrenal hormones, really we have our adrenal cortex, and that's making the steroid hormones. So we have DHEA from the zona reticularis, cortisol from the zona fasciculata, and we do have aldosterone that's controlling mineral balance from the zona glomerulosa. So we'll talk about those a little bit in relationship to signals as well. Now, as I mentioned, sex hormones or just steroid hormones are cholesterol based. So they're hydrophobic, which means water fearing. You can kind of see this picture demonstrating, I was trying to capture, right, that oil droplet. Whereas they're lipophilic, they're fat loving. So they do require transport, and that's primarily through a protein called sex hormone binding globulin and a little bit from albumin made in the liver. And then we also have cortisol binding globulin. So that's on the other side. And these transporters are regulated by inflammation, by things going on in the liver, by stress, by our rate of metabolism. So important to remember that it's not just the production of the hormone and what's in circulation, but also how the proteins are interacting with those hormones. And just as a reminder, because they're cholesterol based, they can pass right into the cytoplasm of our tissues, where they bind with the receptor to make a hormone receptor complex that goes into the nucleus, the control center of the cell, and it augments cell behavior. Once that hormone has acted within the tissue, it now has to break down. So all hormones go to the liver to die, right? And so that's where they get processed out of the body. And they have to be made into a water-soluble intermediate. So we have these phases of detox, right? We have this hydroxylation phase where that steroid becomes a water-soluble metabolite. They still have activity in the body, so that's important to remember. Phase 2 deactivates those metabolites. And then phase 3 is excreting those out. So really in simple form, and I think I go into this in the hormone lecture side as well, but just brief overview. That hydroxylation, that conversion of a fat into water, is through the CYP450 enzyme, specifically CYP1A1, which is the good, the 2-hydroxy, CYP1B1, which is the ugly, right? This is the 4-hydroxy, and CYP3A4, which is like the bad. It does have some tissue proliferative impact, which can be negative if you have a lot of estrogen around, but it can be positive when you're postmenopausal and you need a little extra estrogen response because there's so little around. We also have 5-alpha and beta reductase. I'm bringing these up because there's certain tests that can actually look at these things, right? And so when we're thinking about this, I have my little bucket and broom here. I like to think about this as sweeping hormones into little piles. So we have the 2-hydroxy is really our cardboard, right? It's our recycling. You can build up recycling all day long, and it might become an eyesore or a tripping hazard over time, right? But it's not going to get stinky. It's not going to be dangerous. That's 2-hydroxy. There are issues if it gets too high, but for the most part, it's very stable and it's going to be taken out of the body very efficiently. The 1B1, the ugly, is like your compost pile. If you've ever had compost on your kitchen counter, you know you have to get rid of that within hours, right? It's going to get moldy. It's going to get slimy. It's going to attract flies and other bugs. That's 4-hydroxy. It's not stable. And what it can do is actually become a quinone, which is damaging to DNA. So we really want to make sure that we're not pushing too much into that pathway.
And these are forms of estrogen metabolites, right? Like how estrogen's metabolites. Estrogen. Okay. So, can you swirl around with your cursor exactly where you're talking the good, bad, ugly on the right? Yeah, right there.
So here we have
the 2, the 4, and the 16 there that you're talking about are end results of this process for estrogen, right?
They're a first phase of estrogen breakdown. Yep. So this is specific to the estrogens. Thank you. I get so excited. I just jump right in.
No worries. I was asking for me. So I'm just, I'm guessing if I'm curious, they're curious. So we're good. Go ahead.
Absolutely. Yep. So these are absolutely the estrogen metabolites. So when estrogen goes through the liver, it's passed into the tissues, it's bound to a receptor, it's done its activity in the body. Estrogen is very active, very bioactive. So that's important to remember. But then it has to go to the liver to break down, right? So all of our hormones have to be kind of processed through. There's a little breakdown in the colon, and the fat tissue actually can metabolize some hormones as well in small amounts, but most of our waste is coming from the liver. And again, because these are fat, they have to be made into a water. And these are the conversions enzymes, for that water, right? To make that fat into water. So CYP is these are all hydroxylation, right? They're adding an OH, kind of like water is H2O. So this is like a little water analog being added on to these fats to make them more absorbable and more easily bound. But they still have activity, right? Just because they're an intermediate doesn't mean they're inert yet. And that's why it can become a problem, because 4-hydroxy, right? This is that ugly metabolite. It can still cause damage to DNA. So, and that's the one that we like to watch for, because estrogen itself isn't the problem. It's what it breaks down to. And the 3A4, this is a powerhouse pathway. There's a lot of stuff that goes through this path, but estrogen is one of them. And this is more like our general refuse. I would equate this to like the garbage bin, right? You want to remove your garbage pretty regularly, but it can sit a little longer than the compost pile, right? And that's 16-hydroxy. It's got some good qualities because it can bind to estrogen receptors, which for a postmenopausal woman can give her a little extra bone protection, can protect some of those vascular tissues that estrogen's binding to. Whereas for a woman who makes a ton of estrogen, or a man who's making a ton of estrogen, having that 16-OH can actually be a problem, because now we're getting a double whammy. We're getting estrogen coming into the cell, and then it's breaking down. And then that breakdown product is also binding to that receptor and also causing problems. So it's good to know not just what the hormone level is. We don't want to just know what estradiol is. We want to know, where is it going? And these are the first step of how it gets processed out. And then we do have testosterone and cortisol and progesterone. How do they get metabolized? Well, they go through the 5-alpha and beta reductase enzymes. Again, 5-beta is heavily in the liver, whereas our 5-alpha is in other tissues like adipose. And so you do get some breakdown, and you can kind of see, well, where did this hormone go and where did it transform? And what can that tell us about its activity within the body? So more than just what the hormone level is, where is it going? What is the story of how it's breaking down? Phase 2 is really then deactivating those intermediates, right? So phase 2, I call the garbage bags. And there's a lot of bag options, but for estrogen, there's 2 types of estrogen, the 2 and the 4, that are called catechol estrogens, and these get methylated. So these are going to be subject to COMT, and this is methyl detox, right? So they're going to get a little methyl group bound to them to deactivate them and pull them out of circulation. We do have a little acetylation that's acting on some of our lesser intermediates. It's actually impacting more our polyaromatic hydrocarbons that can impact 4-hydroxy activity. So we like to know about that one. GSTs are our glutathione. And again, you're going to get into a lot more detail, I know, in the future here. But this one can bind and reduce those dangerous quinones. And then our sulfation is happening to the 16-hydroxy. So 16 is tissue active, but not methylated. So it has to go into a different trash bag altogether, and it goes out through the sulfation pathway, as well as glucuronidation. Glucuronidation is really packaging up testosterone and some of our estrogen, our 16-OH in particular. Glucuronidation is also used for some of our methoxy binding. So a portion of methoxy just excretes right out, and a portion does have to be glucuronidated as well. And then phase 3 is really taking this to the dump, right? It's putting the garbage bags into the dump truck, clearing it out of the body. And so this is really our stool. If you're not pooping every day, you have a hormone imbalance, right? And I'm going to talk about why. Because really, once those garbage bags are taken to the dump, are taken to the colon, there's some gram-negative bacteria that make up what's called the estrobolome that make beta-glucuronidase. ACE means it's a cleaving enzyme. So it's going to alter that package. I call these the rats. So the rats come in and they can open up those garbage bags. The liver has taken all of this energy, all of this time to put all these hormones into little packages and get them out of the body. And then it hits the gut. And if you have high beta-glucuronidase, it just recirculates that estrogen. And I can show you that in visual form. This is kind of a cool graph. We have all that hormone going into the liver. We have it conjugating and being pulled into the stool. And then you have this glucuronide stabilizing it. And then here you can see those little rats come in, beta-glucuronidase. cleaves right through that enzyme, opens it back up, and brings estrogen. This is right back into circulation, right into that 17 beta estradiol form.
A
So
plus
now the
for
liver
the
has
for
to
the
work
rat
extra.
graphic.
Yeah.
Yeah.
Thank you. I like the visuals, right? So you're like
Yeah,
sweeping into piles, putting them into garbage bags.
Mm-hmm.
And so it's important. It's important to know these metabolites. Like, do you have an issue with rats?
Yeah,
And
and
you
you're
can
kind
see
of
that.
setting the stage a little bit. I'm going to foreshadow a little because I kind of know where you're going with the testing information is that these metabolites or these secondary versions of hormones, or when they're in the process of being broken down, this can also be tested. You're not just looking at the active, main form of estrogen, the like active testosterone. Like you can test these metabolites, right? And then all of these biochemical processes that are happening here and the enzymes involved in all this, the testing the metabolites allows you to see kind of where along these processes and these reactions are you struggling, right? Is that kind of, am I getting that right for the non-hormone
You are.
expert?
Absolutely. Yes, because it's more than just, I think what happens is when we're looking at hormones and we're assessing them through a lab, too often providers want to make it simple, and hormones aren't simple. And so you can't just look at a single level and make sense of it. You have to see the whole picture. And we'll talk about some peptide hormones as well. So we have our steroid hormones, and those are really our cholesterol based, right? They're the fat based that need transport to get through to all the neighborhoods, right? To all of our cells in our body. But once they're there, they can just pass right in to those tissues, and they can then bind to those receptors. Now, peptide hormones are protein based, and these are signals, and they're controlling production of the steroid hormones, right? So they're really from our control center in our brain. And it's like a knock on the door. The louder the knock, the more that we need that hormone, or the more the tissue is resistant to that signal, right? And so it's one thing to say, oh, estrogen is high, but it's another to say, well, what was the signal? Was the signal too low? Was it too high? What's going on? Where are they in their cycle, right? You can't just make sense of a single value. You have to know what were the signals, what were the messages, and then how is it being broken down? And I'm going to show you an analogy here in just a minute as well that I think will simplify that process. But to put it simply, right, we need piles, we need garbage bags, and we need to make sure the rat population is under control in our gut. I am going to throw out a caveat. Again, with postmenopausal women, there's very little estrogen. And so having higher beta glucuronidase is actually associated with better bone protection because it's allowing that estrogen to get back into circulation, that little bit that they have. The issue being, if they get put on bioidentical hormones, we don't want it recirculating, right? And so now we do want to control the rat population, but there can be a benefit. Our body doesn't do something for naught, right? There's always a reason. And with beta glucuronidase, there is some protective benefit there. We just have to know when we want it and when we don't, and how to alter and what to look for. So really, just as a brief overview or a high level overview, when you're looking at a test option, you need to know what you're looking at. So we have our estrogen, testosterone, progesterone, and cortisol. Where is it made? We have the gonads, right? Ovaries and testicles. Female is F, M is male, or F is female. The adrenal cortex makes a little estrogen. Adipose makes a little estrogen. Even the brain makes a little estrogen. Testosterone, again, the gonads, the adrenals, a little bit in fat, and the sebaceous glands. I have a star here because this is really cool. I could get into this for days, but the researchers are looking at the tissues that make oil in your skin, and they're finding that, often if you have really big, painful acne sores, it's considered a testosterone issue. And so you test testosterone. And a lot of times testosterone isn't systemically high. It's not high in the body. It's not high in the way you're testing. And what they're finding is that, well, there's actually 3 beta HSD and CYP17A1 enzymes in the sebaceous glands. And these are enzymes that can make their own testosterone. So you don't have to have the gonads making testosterone. These little cells in your skin can make testosterone, and that can actually lead to more, and they concentrate DHT, which is it's 4 times more potent than testosterone. So you get like more oil, more production, more what they call end terminal hair follicles as well. So those dark chin hairs, you can lose hair because you also have sweat glands on your scalp, right? You can start losing hair in certain patterns if you're concentrating too much of this hormone. And it may not be a systemic problem. It may actually just be on the skin. So anyway, I digress. Progesterone. we have this transient tissue. And what I mean by that is it's only made for half the cycle. So in a cycling female, we develop these follicles. And when we're ready to release an egg, the follicle has to rupture and the egg is released. And then that follicle caveates into itself and it makes this fatty tissue that generates a ton of progesterone. So women only make a lot of progesterone for about 10 to 14 days out of the month. And it's from that tissue and it only happens if they ovulated. So when you see the surge in progesterone, we can say with pretty good certainty, oh yeah, they ovulated. If we don't see that surge and it's their mid-cycle, their mid-luteal phase, then we can say, ooh, there's probably a problem here. But that's going to be the bulk. And then the placenta also, I didn't have this on here, but the placenta also makes a lot of progesterone. And I do have the reference range down here. Placental progesterone, you can see like 10 times higher, right? We're getting tons more progesterone out of that placental tissue. But again, that's transient. That's only made if you're developing a fetus, right? The testicles do make a little progesterone. It actually helps with sperm maturation. And then the adrenal tissue can make a little progesterone. We're talking tiny bits. We're talking under a nanogram, right, per milliliter. And then the brain. And this is why progesterone can be very healing in TBI, post-traumatic brain injuries. And then cortisol, primarily adrenal cortex. Now, the other important thing is to know, where are they acting? Where are receptors? Well, ovary, endometrium, uterus, yes, lots of estrogen receptors. Prostate has estrogen receptors. This is why estrogens, we want to keep it under control with men, right? Because it can grow the prostate. We don't like that. Breast tissue in men and women. Skin, bone, right? This is why estrogen is so protective to prevent against osteoporosis and why women in their postmenopausal years are at greater risk for osteoporosis. Brain, liver, and heart, right? These are the primary tissues with estrogen receptors known. Testosterone, prostate, right? Big one. Skeletal muscle, it's anabolic. It helps us grow our muscle. Liver, right? Liver's throughout, ubiquitous. And then the central nervous system. And I bring this up because we're going to talk about testing and why this might be impacting testing. And then progesterone, endometrium, uterus, brain, bone, breast, placenta, right? Acting a lot there, made there, acting there, heart and liver. Here's something interesting. Glucocorticoids, cortisol. These receptors are in every tissue in the body. Okay, that's important. And we also have mineralocorticoid receptors, which are a slightly different type of receptor, but also binds cortisol. So glucocorticoid and mineralocorticoid will bind cortisol. These ones are only in the brain, kidney, colon, heart, salivary glands, and sweat glands. Now, metabolism. Where do these hormones go to die? You can see mostly liver, a little in fat tissue for estrogen in particular, and cortisol, a little in the colon, but mostly liver. Progesterone actually heavily metabolizes in the uterus. So that's another important one. Progesterone has a very short half-life. It only circulates for around 15 minutes before we have to make more. And I'll show you a graph of how that looks. It's very bouncy, right, when it's made. Amounts. I want to highlight. Women make the highest amount of estrogen at ovulation. So for 12 to 48 hours, estrogen surges to around 400 picograms per milliliter. Tiny amounts, right? Picograms, small. Very active. Estrogen's very tissue active. We don't need a lot of it, but we don't make a lot of it, right? The rest of the cycle, women are between 19 to 160. Some lab ranges will go up to 220. That's pretty high. Like ideals are going to be that 19 is pretty low, but really around 80 to 160 is a good range for like a follicular phase estrogen. Men are making 10 to 40 picograms per mil all life long. And this is the cruel joke I always say with Mother Nature is, men are making between 10 to 40 picograms of estrogen because it's coming from testosterone. And look at how much testosterone men make, 800 to 1100 nanograms. Whereas women, 15 to 70, drop in the bucket, right, in comparison. But from that testosterone, men make estrogen just a little, around a 2 to 5% conversion, up to a 10% if their aromatase is a little overactive. You need about 20 picograms for bone protection. Postmenopausal women drop below 10 picograms in estrogen. So we're losing our bone protection. This is why postmenopausal women are at greater risk for osteoporosis than men, because men always have a little bit of estrogen, a little more than a postmenopausal woman. Again, we talked about the testosterone, and this is nanograms. This is bigger, right? 1,000 times more than a picogram. Progesterone, variable, but the highest amount is ideally 10 to 20 nanograms per milliliter. And that's only after the release of an egg when we make a corpus luteum. Men, under 1 nanogram per milliliter. That's adrenal and like a little testicular influence. Postmenopausal women, also under 1 because it's mostly from the adrenals. And then you can see that placenta, again, 350 to 400, like whew, tons of progesterone. Now, cortisol, 10 to 20 micrograms. Okay, and I'm putting this out there because I want you to know how much is being made. Cortisol is needed for the metabolic response of every tissue in the body, and we make a ton of it, right? Micrograms. If you think about this, 20 micrograms is 20 million picograms. That is a ton more than estrogen, hundreds fold over estrogen production, right? Really, hundreds over testosterone and progesterone. That's 20,000 nanograms is 20 micrograms, right? So we make a ton of cortisol, and that's important when you're looking at test options. So units really do matter. I always like to put my references, so I think you'll have access to these slides afterwards if you want to see them. So how do we test our hormones? Well, we want to keep all of this in mind, right? What are we looking at? Where are they active? How do they circulate? What are their values? Now, before I really dive into those tests, I do want to bring up the concept of spin and snout. So spin and snout are sensitivity and specificity, and this is the geeky brain coming out. But when you're looking at a test, you want them to be both sensitive and specific. What does that mean? Well, specificity, the easy acronym is SPIN. Specificity is if it is positive, you can rule it in. Sensitive is snout. If it is negative, you can rule it out. Now, it's reverse what it's actually telling you because it means that a sensitive test is a true positive. That's really what it's looking at because you can rule out all the others. If it's negative, you can rule it out, which means you get a true positive. And conversely, with specificity, it's the true negative. So ideally, you want a test that's usually about 80 to 90% specific and sensitive. And the type of test matters because you want to look at, like, is this immunoassay? Is this immunoassay is kind of a very broad way to test? Or is this more like focused? Like immunoassay doesn't have very good specificity, but it has great sensitivity. Whereas mass spec has really good sensitivity and specificity. It's just a little more expensive. Now, sensitivity does come into play. You can use a highly sensitive test that's not specific as a screening tool because you're going to catch a lot of positives. But you're going to have to confirm those positives, which means if you do get some false negatives in there, or some false positives, if you get some negatives in there that were coming up positive, you're going to screen them anyway. You're going to have to retest and make sure that they truly have it. So then you confirm them, right? So a screening test, you can have a good sensitivity, but not specificity and still have a decent test. And we see that with OPK, ovulation predictor kits. They're sensitive, but therefore the surge in luteinizing hormone that comes up in urine, right? They're a sensitive test. You do get, like, if it changes color, it's likely that you ovulated, but it's not confirming that you ovulated. You still need a blood test to say, where is your value following that surge, right? Accuracy and precision are also something you need to consider. Accuracy is the test reliability. Precision is the ability to get the same marker every time. You get accuracy and precision with standardization. And this means, how was the sample collected? In what medium was it collected? In what type of vial was it collected? These are all things you have to consider. And we know that with, for example, a blood test, the phlebotomist uses a certain caliber needle to make sure that they don't break down the blood cells, to make sure they don't break down and artificially inflate certain values. They use a specific colored top. If you're sitting at, a lab and the phlebotomist is coming out with all these tubes and they have different colors, those colors represent different things that are within the tube that help pull out and extract what we're looking for, right? So they're going to use the right tube. They're going to use the right needle. Your doctors hopefully told you how to test in the morning and fasting because that's necessary. That's how we've validated hormone tests in particular. How is the lab then? How do you transport it? Are you transporting it on ice? Are you transporting it at room temperature, right? How fast does it get to the lab? How is it processed? How is the lab handling it? These are all steps that you really have to consider when you're looking at a good lab and trusting that their data is true to what you're looking for. I'm putting this out there because salivary testing in particular lacks standardization. There's different types of collection mediums. The instructions vary across the board. I've had different instructions where some say, use citrus, right? In order to increase salivation. Well, guess what? Using citrus, if you put it in your mouth, to increase your rate of salivation, now you've just ruined the pH of that sample. Now the information is not good because it was calibrated to collect a more basic pH, a higher level of pH, and the citrus lowered the pH. So now we're getting a different value just because of how you collect it, right? Because the lab didn't specify. Brushing your teeth can overinflate values in saliva, which we'll talk about why. So really with blood, we know it's been standardized. We know exactly how to collect, exactly how to transport it, to use it, to look at it, right? As long as the lab is calibrating their machines, you get a good value. Salivary, we're going to talk about. Urine has some pros and cons as well. So we'll talk about those. And this is just that accuracy and precision and showing you in a visual form, right? We want both because we want to hit the target every time. Now, when we're looking at the different lab options, the big ones out there are going to be the blood, right? So serum. Saliva has come up on the market as a big testing option. And then urine. So when you think about this, think about the brain. And I like to think about this as like an Amazon fulfillment center. So the brain is like the Amazon order. And it's sending out peptide hormones and saying, hey, we need to make more estrogen. So we're going to send an order down to the ovary to make more estrogen. The ovary starts generating estrogen. And it will use it at the tissue level, but most of it is going to get bound and loaded up onto a van, right? Now we have to take that van and we're going to drive it around all of our neighborhoods. So as we're circulating, that hormone's going all throughout our body, right? There's no turnoffs, but it can decide to unload packages or not. So we have this van running around the body, right? Going to all our different tissues. That's what we're seeing in blood, is we're seeing how much was on that van. And we know that in the morning, we get our peak level. So if we are collecting a morning fasting sample, we're going to get a good representation of production, what was on the van. Now in saliva, you're getting what was dropped off at the doorstep. And there's going to be some caveats to that, but what was dropped off? We don't know if it was taken in. We don't know if it was utilized. We just know it was there in free form because saliva is fat, right? It's a tissue. It's a salivary gland. So it's lipophilic. And you can pass right, that hormone can pass right through if it's free into that tissue and spit out into a tube, right? So that's really what was there at the doorstep. Urine is what was at the doorstep, but then brought into the cell and unpackaged. And did we break it down into mostly cardboard waste? Or was there some nasty stuff in that box and we were putting it mostly in compost? That's not good, right? We want to see that. How was the package not just taken in, but also broken down to see truly the metabolic story? What is happening to that hormone and what would be impacting that activity? So with serum, this really is our gold standard, but it has to be LCMS. That's liquid chromatography and mass spectrometry. This in many labs is called ultra sensitive and it is more expensive. But often insurance will cover it if you know how to code for it, right? But it is usually covered by insurance. You're collecting blood. So there is the issue that it is a needle stick. And if you have that vasovagal response and every time you see a needle or you get poked, you pass out, this is a very real thing. This might be a trauma, right? A trauma experience to get blood tested, right? I know. Yes. Michael's raising his hand because he experiences this. So you do have that issue of like, you have to go to a lab. You have to get poked. Ooh.
My hands are sweating right now just because you're talking about this slide. So if there's anybody out there with a similar, it's totally fine. I'm used to it. I'm not like sick or dizzy or anything. If we got really into it and you talked specifics about it, I would. But I'm sure there's people out there that while you're talking about this are feeling the same thing. So I just want to give them a shout and let you know that you're not the only one that's irrationally phobic of blood draws. Okay, go ahead.
No, not at all. It's a very common phobia. Absolutely. Like, it's a natural response to want to protect your body from harm. And
and like logically, my brain, like I'm aware that because I have to do phlebotomies because I have high iron. So like if I give blood or if I have blood drawn for a blood test or I receive a shot of some kind or I'm hooked up to an IV, I'm like logically aware that it's not going to kill me. Like it's not dangerous, that it's painful a little bit, but it's not even that painful. Like I have tattoos, like that hurts 1,000,000 times worse than getting a blood draw. And it doesn't matter. There's like this deep intrinsic, like, that's not supposed to happen to me. Pull your arm away, get away from this thing. And I did have medical trauma when I was little, a little bit, but I don't think that's even necessary. I think some people are just scared of it. So I want to normalize that and let people know that they're okay. Try hypnotherapy, try some other things. I haven't found a golden ticket for myself yet, but if you do and you get over it, reach out and let me know how you did it, because I'll do whatever you did.
I mean, it's definitely, yeah, yeah, let me know. Give tools to my patients. I've tried a few things with patients, and one thing that seems to work okay, right? Because it really is, it's the autonomic nervous system that kicks into overdrive, right? It's fight or flight. It's like, adrenaline's coursing through you. And it's like, oh my goodness. And you can't control that rationally, because that's triggers from your body that are saying to the brain, nope, this is not a rational thing. This is dangerous. And one thing that you can try is counting in non-sequential order, right? So it's like 1, 7, 10, 22, 16, 8, your brain, the higher the prefrontal cortex has to think through non-sequential counting. And so you're suddenly taking yourself away from that amygdala fear response, that kind of like animalistic kind of artifact in our brain that's so triggered by like, oh, it's hot, it's dangerous, you gotta run. It takes you out of that, and you can start to then pull into the rational brain a little more. And that has seemed to help with patients. It's just like, as you're like, don't look. I don't, like some people are like, oh no, I must. It's like, no, don't look.
Oh, no, no,
Because
no, no,
that's
no.
going to also trigger. Yeah.
No, and I've noticed if you tell, that's a good tip. I've never tried that, but if you tell nurses that, like, I always warn them, because if I'm going to pass out, like, they need to know that, because they'll have me like lay on the thing instead of sit in the chair. And
Yeah.
I'm bigger than most of them. So if they need to know that, like if they're going to need a second person or whatever, but they'll always, and I find it obnoxious when they're doing it. It's like, cliche kind of small talk. They ask me questions. They ask like where I'm from or where I live or what I ate for breakfast. And I know, my brain knows that they're doing that to distract me from the thing that's happening in my arm. And sometimes I'll shut them out and I won't respond. And that's when it gets really bad. And other times I'll be like, fine, I'll play your stupid game and I'll answer their questions, because I'm in like an agitated state. Like when this happens, it's not normal me. I'm not like funny and happy. So what I've noticed though, begrudgingly, when I do answer their questions and I play along with their game, I do get less dizzy. I do have less chance of passing out. I do get less sick. Like the response is weakened, and then it's over, and then I'm like, fine, it worked. So
Yeah.
definitely, I agree with the engaging the part of the brain that isn't the lizard brain that's terrified of the needle and is the thinking brain. But I don't want to keep hijacking your show. So go ahead, and thanks for the tip. I'm going to put that in the
Okay.
notes.
Absolutely. Anything to help. Because really, when you are looking at blood, it does give you so much. And it is an important way, a metric to look at what's happening with the production. How much is on the van? How much did we get loaded into our trucks? Right? And we can see those peptide hormones really well in blood. So what are the signals? How many orders came into the tissue? What was our brain doing to say, hey, this is the knock on the door to get you to start ramping up production? We need to know that whole story, right? But it has its limitations because it is a snapshot. It's going to be a single point in time. It's what passed through when you took that sample. And you're not really seeing metabolites, with the exception of DHT, which is dihydrotestosterone. It's a very active intermediate of testosterone, which is kind of, it behaves as its own hormone. You can look at that in blood, specifically for men, because they make a little bit more of it. Now, just as a comparison, I told you about the immunoassay versus mass spectrometry. And here you can just see, this is for testosterone. It's been well studied. It's one of actually our longest studied and researched hormones. But immunoassay, this is what they're doing. They're just mixing it with these tracer elements and antibodies, right? And throwing it into the sample and saying, well, if it's this concentration, then this is the level that value is. It's not sensitive or specific. I mean, well, I will say it's sensitive. It's not specific. It can't identify exactly what the value is, but it's saying, yeah, it's high, or yeah, it's probably low. But if it's too high or too low, it can't make heads or tails out of it, right? So it's cheap, right? And it's fast, and it's got quick turnaround time. And the calibration isn't that hard. So a lot of labs opt for immunoassay, but it does have its limitations. Whereas mass spec, this is like they're identifying the exact amount coming through that sample to that. They're looking at these little waveforms that are identified. It's a fingerprint. It's a fingerprint of the hormone. So they're looking for these fingerprints to say, oh yeah, this is how much fingerprint there was there. And it's very good at collecting those very highs, very lows, and everything in between. As just a reference, if a lab can't be sensitive enough to define whether an estrogen sample is a postmenopausal woman or a low cycling luteal phase woman, that is a bad lab. If there is overlap in those reference ranges, that means that is not a very specific test, right? You're not getting very good data because there's no way there should be overlap there. You should easily be able to say, yes, this is a postmenopausal range versus this is a cycling female, but she's just low, right? So just a little aside. Saliva, again, non-invasive, right? So you can spit in a tube. It captures the free hormone. So it's passing. So I'm just going to give you a little visual here. So this is our blood vessels, right? We have capillaries all in our gums and our teeth and our salivary glands, right? This is why, if you bite your tongue, you bleed profusely, right? Because there's a lot of blood vessels there. And so those trucks are passing through all those tissues. If they have free fraction, it can easily, if it's free off the truck, it can easily pass right into those fatty tissues of the salivary glands and concentrate in that tissue and then get spit out, right? But we have to take into account, and this is why I always ask, I'm like, okay, well, how are they calibrating this, right? So is there good blood flow into the mouth? Is there good salivary flow out of the mouth? Is there too much salivary flow? Or are we excreting so much that it's actually overinflating or under representing a value? And again, why would a hormone be free at this junction? So why would a hormone be in the salivary glands? Now, we're not going to see any of the protein-bound hormone. Again, this is really susceptible to interference. If you brush your teeth and you have any inflammation in your gums, or if you just have inflammation in your gums to begin with, and you spit into that tube, you can see up to 30% greater testosterone value than what is actually in your tissues, right? And that could if all you're looking at is saliva, that can give you an inflated value of that testosterone marker. Why would that happen? Well, remember, testosterone is in the central nervous system. It has receptors. Testosterone is anabolic. It helps grow things. It helps differentiate things. When we're inflamed, we concentrate testosterone in order to activate white blood cells. We're trying to improve and reduce inflammation and support our immune system in our mouth. So yes, there is a lot of testosterone in that tissue, but it doesn't equate to what's happening in the body. It's not what was made in the gonads, right? It's not what was in the tissues and actually getting used by the skeletal muscle or the brain or the bone, right? It just happened to be concentrated there because you had an immune response. So I think there's this issue where we're saying, oh, well, if it's there, it must be representing all the free fraction that's in the body. But does it, right? Now with cortisol, I want to come into saliva and say what is really good in saliva. And cortisol is really good as a measure in saliva because you're capturing so much, right? We have so much more cortisol and it's everywhere and it goes to all the tissues. It absolutely is passing into that salivary tissue and it absolutely can be excreted out and caught and captured. What happened was researchers and doctors alike were like, oh, if this is really good to catch this steroid hormone, then it must be really good at all other steroid hormones. But remember, saliva is usually an immunoassay. So it's not a very sensitive test to begin with, or a specific test to begin with, right? It's a screening test. More labs are coming out with LCMS, but again, their standardization isn't there. And what we're trying to capture is the free fraction of hormone. When we're looking at estrogen, there's not much there to begin with. So we're trying to capture a very, very, very small fraction of hormone in a tissue that estrogen doesn't naturally gravitate into in the first place, right? So estrogen, you're not going to see it well represented in saliva. Progesterone, you could, right? We make a little bit more progesterone, especially in the luteal phase for cycling women. So that could be okay to avoid the needle stick, right? You could see that hormone possibly equate as long as you're not on bioidentical hormones. As a baseline, saliva can be used. Testosterone, mostly protein bound. And the only reason it would be free in the saliva is because of inflammation, right? So what is it showing us? What is the story? So you have to know what you're looking at. And I think too often we try to make it simple and say, well, if it shows this, then it obviously shows these as well. But we have to ask ourselves, well, why would that hormone be in the saliva in the first place? And there are some arguments. People don't know. The bottom line. They know why cortisol is there because cortisol is everywhere, right? So it's a great medium to test cortisol because you can get lots of samples throughout the day and really see what they call the diurnal rhythm. So the rise and fall that we expect with cortisol. What is your rhythm? But we're making extrapolations, I think, that are somewhat artificial and not well vetted. So why would they be there? Well, there's actually, when I just typed into the research database, like, why would a hormone be in the salivary glands? Well, the big one is it's possibly pheromone, right? This is an artifact of our mammalian days when we had pheromones that would attract mates and attract and like represent health status, right? And lots of mammals are still excreting hormone in this way. We just don't have the parts of our brain that connect to it the same way, but we still have that artifact, right? So sweat glands, pheromone, right? Salivary glands, all connected. So if these are an interconnected kind of external representation of hormone, that's kind of what we're seeing. And that's what I've seen with the research, right? And you can see this a lot with topical hormone use. So you put topical hormones on your skin, progesterone doesn't tend to get into the tissues very well because it has a short half-life, right? And so yet you test it in saliva and it's through the roof. And people are like, oh, of course it's getting into the tissues because it's there, right? It's in the salivary glands. It wouldn't be there if it wasn't in the tissues. But my question is, well, what if it's just that, it's a pheromone circulatory system? Some docs will say it's more lymphatic based, but like, what if it's just this external expression? Because if you look at the tissues that are deeper, if you put a woman on bioidentical topical progesterone and you do an endometrial biopsy, that's where progesterone should be. They don't find progesterone. So it's like, okay, it obviously didn't get deep into the tissues, but it is somewhere because it's in saliva, right? So this is where it's like, well, is it this external representation versus a deeper internal view? We see this with testosterone. Testosterone does absorb really well as topical, but often doctors will underdose it because they're seeing super high levels in saliva. But here we see testosterone should drop the signals in the brain to make more, right? It's a negative feedback inhibition. If you have a ton of testosterone in your tissues, the brain's going to say, oh, we don't need to make any more orders. We're going to drop our order count, right? So LH should come down. There should be that conversion into estrogen, just a hair, right? And we see that when we are on a good appropriate dose of topical testosterone. It's raising the blood levels. It's raising the urine levels. It's doing the right feedback inhibition, telling us it's in the tissues. And yet, if you look at saliva, it's going to say it's sky high, right? Because it's external representation. That's really kind of what we're seeing. Some people say it's more of a fat representation as well. So the bottom line is we don't really know. And in fact, this study, these are the topicals here. Same thing with estrogen, right? We can look at bone turnover markers. CTX is this C-telopeptide that is a cross-linking collagen 1 marker. And when it's high, it tells us there's a lot of bone turnover. And if you put women on estrogen, topical works really well to protect the bone. And you can see that marker actually stabilize. But if you put them on lower doses, and because the salivary is saying it's way high, you actually see that marker start to go up again. It's telling us it's not getting into the bone, right? It's just in the saliva because it's just in this weird circulatory system that's external and not internal necessarily. But that's just, these are just my questions. Bottom line is we just simply don't really understand that salivary connection outside of cortisol, right? Progesterone, again, baseline progesterone is probably okay. Testosterone, do blood. It's protein bound. Estrogen, there's this study called Not Within Spitting Distance. And this study goes into exactly how poor salivary estrogen measurements are. It's noise. It's just bouncy. It's just all up and down. There's no rhyme or reason to what values. Like they do these cross split samples and they're like, well, this one's saying it's high and this one said it's low. Like, how are we differentiating this? So not a good way because there's so little, right? And it's not going to get into the salivary glands usually. This physiologic role of hormones in saliva, this is talking about that pheromone response. And really, it's actually looking at tumor use. And because there's certain tumors in the kind of head, nose, throat, tongue, oral, the what they call the nasopharyngeal kind of cavity, that do make hormones on their own and are in free form. And so they're actually like saying, well, this could actually be a good way to be a tumor marker, like is looking at salivary hormone, but not for like physiologic activity. So, and then just, guidelines based off of what we know is a good sample and how to test. And then in urine, I'm just going to breeze over this because we've talked about it, but this is really bioavailable. It's what was brought into the tissues and unpacked. And it's your daily average, right? So we're taking a point in time with saliva and blood versus all the average of what's happened and passed through those tissues and excreted out into urine. Why does that 24-hour sample matter? Hormones are bouncy. There's diurnal rhythm to the hormones. If you're not catching at the right time, you're missing possibly their surge. Whereas in urine, you're seeing that total value over time. You're seeing their daily average. And I just wanted to throw in a quick case because I thought this really hits it home. Here's a 28-year-old female. She has fibroids. We know this is an estrogen dominant condition. She wants to get pregnant. Well, the type of fibroid she has, it's either controlled by birth control or surgery, and she could lose her uterus, right? So yeah, we don't want these options. There are some medications, but it makes it harder to conceive. So we do her blood. Look at her estrogen, 29. It should be 56 to 214 if she collected correctly. We know she's luteal because her progesterone's high. It's only high if she made an egg and she had that corpus luteum, right? So we know she collected in the luteal phase, but what's going on with estrogen? She should be estrogen dominant, right? Testosterone, we also ran kind of on the lower end. I'm just going to breeze over that because here we did the urine on the same day. And look at her urine estrogen. It's on the high end of range. And look at the 16-OH. You don't get that in blood or saliva. But look at how high that is, strongly connected to fibroid tissue growth because this is a tissue promoter. This goes back into circulation and rebinds to those estrogen receptors. We don't get any of this, right, with any of these metabolites with any other medium outside of urine. So then we have to ask, well, why is there such a discrepancy, right? 29, she should be this 56 to 214. Yet urine is saying she's great, she's high, right? Well, she did collect on the same day, but turns out she was collecting her urine all day long. She collected her blood at night because she could only get into the lab after work. So she knew she was supposed to go in the morning, but she couldn't carve out the time for it. So she collected at night and she got that low dip in estrogen, right? She was at a point when estrogen was declining. And so we had an artificial low. She wasn't probably low all day. Obviously, we know she wasn't low all day because we have her average in the urine. But we would have missed that and we would have mistreated her had we only looked at that blood sample and not taken the whole picture with the urine. Now, this is a lot of complexity, right? As I mentioned, I'm the director of clinical sciences at EndoAxis. When we're looking at these labs, it's like, well, sure, this is all well and good, but this is hard. Like, I don't know to look for 16-OH. I don't know what that means. I don't know what these trash bags mean. I don't know what to really pull out of this outside of just what the levels are, So that's where we come in. EndoAxis is a system that is free for providers to analyze these labs and connect the dots for you. And it's simple. You just upload the labs. We do take your symptoms into account. We take in age. We take in your cycle status. We're putting you into these groupings of patterns, of which there are a lot. And these are relationship patterns between what are our ideal ranges, where do you fall within those ranges, and then where do you fall within yourself? How do you compare to your metabolites? What are your ratios amongst how you break down these hormones? You get a very detailed report, usually 11 to 14 pages in length. And then you're partnered with one of our, or several of our 26 formulations. We have foundational formulas and complementary formulas. And you get, so there's 26 of them in total, but you're getting a combination of usually 1 to 4 groupings for your unique imbalance. If you do, 26 to the power of 4, you're getting over 1,000 different combinations of these formulations. So you really are personalizing treatment to what your imbalance is. All of this to say, here's my ideals for hormone testing, right? You can't get away with a single value in a test. So whether you're using blood, saliva, or urine, you have to look at the whole picture. So never just look at a single value. Always ask, what are the peptide hormones? What are the signals, right? What is the actual distribution center kind of loading up on the vans? This is why I like blood, right? And then how is it being unpacked? And I think there's just too much unknown with saliva. Not to gripe on it. I know a lot of docs use it, but I just think that we're not asking the right questions and we're not assessing it correctly. And labs haven't standardized their ranges, right? You're getting these split samples that are across the board on the same person at the same time. It's like, we can't make heads or tails, but we can with blood, we can with urine if we know what we're looking for. So what do I usually run? For the peptide hormones in blood, I'm looking at LH and FSH. If they're cycling, it's on day 3. Why? Because day 3 is when everything should be at a nice baseline. After that, things start to bounce all over the place and doesn't really mean anything. But on that day 3, day 2 to 3, day 2 to 4 is kind of your window. LH, FSH, thyroid is TSH, free T3 and free T4. You can get that in blood really well. Again, you can do LH in urine. This is your ovulation predictor kit. It's sensitive. It's not specific, but that can be a nice way to gauge where you're at in your cycle if you need. You can get the binding proteins in blood. You can't get that in urine. You can't get that in saliva, right? Steroid hormones. You're going to get the LCMS, and you're going to get a fasting morning blood draw, right? Because you want to get your peak levels. How much did you create in response to your biggest order, and how much was loaded up onto that van, right? In the urine, you're going to get your daily average of all the metabolites. It's the only way you can collect those metabolites, to see everything that passed through the liver, right? Yes, it is a waste, but it's a waste that shows us metabolic impact. And that to me is a bigger part of the story that really makes a lot of impact in terms of treatment for my patients. There are some special tests you can do in blood as well if you're looking for fertility, if you're looking for like where are they in their perimenopausal journey. Anti-Müllerian hormone and inhibin B are markers that you can look at that look at follicular reserve. So how many eggs do you have left coming up to bat? 17-hydroxyprogesterone actually has to be collected day 3 before 8 a.m. for accuracy, because this one's one that surges and drops. So for accuracy, you do need that before 8 a.m. This is looking for a condition called non-classic congenital adrenal hyperplasia, NCAH. This is often misdiagnosed as PCOS. So it's a nice one to know. Is this adrenal androgen dominance or is this ovarian androgen dominance? Because treatment differs. And then prolactin. And then in urine, you have, organic acids that you can see. So I know I went over, I know this is a lot. If you want to learn more, it is free to sign up as a provider. And this is our QR code. If you are a patient, I know Rebel Health Tribe does offer both the ability to get the lab and to interpret the lab through EndoAccess if you're interested. So I'll let Michael speak more on that. If you want my references here, I'm going to be sending all these slides over so you'll have access to this as well. And that is hormone testing in a nutshell. I hope I didn't go too much in the weeds.
No, you're great. I'm going to just make a note. Slides. We'll include your slides in the package too, because I think that they're would be really, really helpful for people with this. And I like that this, as always, you over-delivered, and that this can be used by patients who want to really educate themselves as to, am I getting good care when it comes to hormone testing? Are my doctors using the right technology or the right method of testing? Are they looking at the right things? Are they taking the test at the right time? Am I getting it drawn at the right lab? I've never even thought about some of those things like that. So, and then for practitioners, this is an invaluable resource that I think could really, really help a lot of practitioners make a much more informed decisions that'll be more helpful and more valuable for their patients and clients. So thank you so much. I want to give a shout to cholesterol. I'm doing this in every presentation in this masterclass because cholesterol has been made the bad guy for a really long time. And so far, it's been at the top of every chart that's been shown on every presentation for the masterclass so far as to where hormones come from and how they're made and the essential building blocks of them. And I heard you mention it a few times, so I'm just trying to de-vilify cholesterol. It's not really a question. I just want to give it a shout. And then Absolutely. I found it, if you want to say something on that, I'm sure you run into that with patients that think cholesterol is bad because they've told us that forever.
Oh my gosh. They have. Well, and here's the thing. Like if you look at reference ranges and what they used to say was totally healthy, fine, and normal, it used to be 220 nanograms, right?
Just keeps eking over.
Since the advent, right, of statins, they want to get these medications out there. And it's like statins in the research have not ever been shown to reduce the occurrence of a first heart attack. It's the second heart attack, right? And they're studied, sorry, this is like a soapbox of mine, but they're studied on 65-plus-year-old white men. They don't look at them, they're starting to look at them more now in women, how they affect women, how they affect people of different ethnicities, different age groups, right? Like this was never tested initially. It was just like this very narrow market. And it's like, it does work for that one client.
They're selling a bazillion of it, and then it's linked to neurodegenerative conditions and all kinds of other things. So like
men especially, right? Because we need our cholesterol.
Yeah, and I saw one study that was pretty large and pretty convincing and pretty solid that showed a linear relationship between cholesterol levels and lifespan in women
Yeah.
over 65. The higher the cholesterol, the longer they live. In a linear, they were the same line. And within the margin that was not statistically possible for it to not be related. And I don't know the right terminology, but it was really convincing. So cholesterol is not the bad guy. I want to bring up that you mentioned that testosterone is made in skin cells. I've never heard, or not in the skin. I've never heard of that before. And it makes a lot of sense as to
It is so
why
crazy.
people with certain skin issues will run hormone tests and their doctor will say your hormones are fine, let's throw you on these antibiotics,
Yeah.
and the testosterone being made in the skin is not showing up on the test, so then it's not relevant or accurate. So
And I actually do have in Oregon that will do biopsies of the sebaceous glands and test for DHT concentration
well,
levels.
most
And
practitioners, that's an extremely rare case, I'm sure.
yeah, yeah, it is. And, again, this is newer research. I put the asterisks there
Yeah, yeah,
because they're
yeah.
still investigating it, but it's really interesting that we would have those CYP conversion enzymes to make hormone in those tissues. It's not just
Yeah.
that it concentrates it, it's that it could actually make it, which is, just
Any
blows your mind,
news or
right? When it
tips
comes
or updates or useful information that people with like bad acne can get is welcome. I had pretty bad acne when I was like teenager, like late teens, 20, early 20, and it sucks. Like it's terrible. And um, I didn't know any of this stuff, and I was doing a whole bunch of the "don't do this if you don't want skin problems" things, and I had no idea. But it's always helpful. And then the last thing is that I don't have any questions. You answer my questions way before I can even write them down. So is the factoid that postmenopausal women have lower estrogen than men, therefore higher incidence of bone loss and more risk for bone breaks. And I find that really interesting because the men's level is low, but it never changes the production of it. Essentially, it can because of the
well,
aromatization, and that can get higher when you get older. But like, it never
you actually get
significantly changes to like a high level or like lower than that range very much. Whereas women go from one extreme to another, and it'd be like akin if men's testosterone went to like zero when they crossed 40 years old or something, which it's starting to. That's a whole nother presentation. But I find that really interesting. And that estrogen hormone replacement therapy for women has been vilified in the functional medicine and the natural medicine side of things because of those metabolites you talked about. Some of them, if they're significantly elevated, can be higher risk for cancers, can be higher risk for a lot of problems that people don't want. And so it's like throwing the baby out with the bathwater, that like using hormone replacement therapy equals more cancer, equals more this. And it has everything to do with how those hormones are being metabolized, right? And you can test that with the urine testing, which would be a great adjunct to any hormone therapy to make sure that the hormones are being utilized in the right way, are being trash sorted and recycled in the same way, are being taken out properly, and are actually leaving the body. Because I would guess if you're taking a bunch of hormone and you know that, and then you're seeing low levels of metabolites or low levels of clearance in the test, there's something's awry. So you can it's an essential tool to monitor safely hormone therapy, right?
Yeah. And again, it's non-invasive. It does show up. So here's the kit. I think I breezed over this one and I apologize. So for those who are still listening, hopefully you are, when you're looking at urine, topicals represent really well in urine, right? Is it getting into the tissue and how is it getting broken down? Injections, pellets also reflect pretty well in urine. Saliva, or because you're looking at conjugates, anything taken oral or sublingual. So if it's getting put and swallowed, you're subject to first pass, which means it's going to hit the gut and break down and clear out of your body before it ever gets into the tissues. So in urine, you get an overinflation of oral and sublingual hormones. So that's the kicker there, is that you can't really track those ones as well. You can get low end therapeutic, kind of where do you bottom out if you stop the hormone for about, depending on the hormone, 48 to 72 hours. So you can see your low end therapeutic range, which is still beneficial. But if you take it actively while you're testing, you're going to be overinflated with your hormones, not because it's a lot in your body, but because it's just excreted out, which again, with topical hormones in saliva, you overinflate, whereas you accurately reflect more so in urine. And again, I would argue it's because you're excreting external versus deeper internal. And again, I think there's so much unknown with the saliva and just asking the right questions. It's not to vilify it. I think it's a very intriguing way to test. It's just cortisol would be a great one there, right? Cortisol is a great one in saliva. And I didn't put that on my chart, but cortisol, do that in saliva. That's the ideal gold standard. Other hormones,
Perfect.
why are they there?
And I want to address the EndoAxis. We do have that available. There's going to be a package offered available to those who attend this, who want to try it out. I don't know at the time of this recording exactly what that's going to look like, so I'm not going to give details on it right now. But if you're watching this, you will be communicated with by us, from us, about Dutch urinary hormone testing with the EndoAxis interpretations and everything she talked about. That they basically took Dr. Liz's brain and put it into that software. I know that's not her clinical way of explaining it, but that's what it essentially what we're looking at. And if you're a practitioner listening to this, you definitely want to jump on board with that, because it's free to use and you get the reports, and the learning curve on urine hormone testing interpretation, if you're not already doing it as a practitioner, is steep. And so it's to get it right. You can get the high level gist of some things pretty easily, but to be able to look at all the patterns and everything, and to be able to put the pieces together to figure out where the dysfunctions are, requires a lot of help and education. Or you can get these reports and they'll tell you what to do. So it's a great service, a great tool. We'll be sharing it with everybody, and we might even have you come on and answer some questions about it or something closer to when this airs, or just after this airs. So thanks again, Dr. Liz. This was super thorough. I think that this presentation, especially for practitioners, is worth more than we're going to be charging for people who want to purchase all the recordings and the bundles and everything else. So definitely essential knowledge for anybody who's working with hormones, or who's just a patient and wants to get on top of their hormone testing and really advocate for themselves, which gets brought up in a lot of these presentations, is self-advocating and knowing what you're doing, or knowing what you need to an extent, so that you can make sure you're getting the best care. So thank you so much. It was awesome as always, and I look forward to connecting soon.